So welcome everyone to this Let's Code Together webinar. My name's Jane Knight and I'm an instructor with the Medra MSSO, and I'm joined also today by my colleague Dr. Carol Ann Wilson, who's one of our medical officers.
Hello and welcome everyone.
So it's very nice to have you all with us today. Just a couple of points to note: that the session will be recorded. We don't distribute the slides from this session because it's a workshop and it's a live, more of a discussion session than a presentation. So we don't distribute the slides, but the session will be recorded and will be put on the YouTube channel. The other point to note is that we don't offer certificates for webinar participation, so you won't be receiving a certificate, but you will get an email that confirms you attended today with a survey link as well afterwards. So Okay, so the first slide just explains that Medra came about in the mid-1990s, and at the time the MSSO was put in place to maintain and distribute Medra. The activities of the MSSO are overseen by a management committee with representatives from across the ICH regions, both the regulatory authorities and the industry. The copyright notice that explains Medra is owned by ICH, as is the material that we're using today. And if you choose to use any of the material afterwards, or you must acknowledge ICH as owners of that material. So I mentioned to some of you who are here early, we do want to make this into a workshop format, and we want you to be as interactive as possible to join with us. We're not able to see you nowadays in classrooms, so this is the best we can do. And we are interested in your comments and your questions. So please use the questions, or it might be called questions or chat, in your GoToWebinar panel to ask your questions and make your comments. We may not all agree. Sometimes we will have to agree to disagree and move on in the interest of time. We've got a lot of examples for you today, so we're hoping to get through as many as possible. We can't take requests during the session to code specific verbatims for you, but what we can do is, if you're interested, if you've got any examples of terms that you've come across that you think would be interesting, there will be an option at the end for you to propose examples for us to consider for future. But these must be of general interest, not so specific to your therapeutic area that they won't apply to others. So this is the polling. We mentioned we would like you to participate. You can do so on your mobile phone or on an internet browser. What you do is you open a browsing session, and into the URL field, you type poll.ev.com, poll.ev.com. This then takes you to the Poll Everywhere application, and you need to enter my name, Jane Knight 855, as the username. It's anonymous, so nobody will know your name, and you need to enter my name so that you can link to my presentation. So Jane Knight 855, because the presentation's in my name. That will allow you to join. And here we've got a tester to test, is it working? Where are you in the world today? Where are you joining us from? Oh, Spain, France,
yes.
Ireland, Germany, Portugal, India. India's gone.
Italy, buongiorno.
North America. Good morning, good
Portugal, bon dia.
Portugal. It's great.
France.
You're quite a small group today compared to some we've had, so please do join us and make your comments so that we can make it interactive. We've also given you temporary access to the web-based browser. If you don't have your own access, then you can use this one. So Carol Ann's going to put the details in the chat for you. So, or if you want, you can take a screenshot, take a photograph of the page. This is a training access that will only be valid for this week. So if you don't have ready access, you might be glad of that. And then moving on. When we say every time, coding, there isn't always an exact match. Sometimes there's more than one possible LLT that you could choose. And even the points to consider document sometimes gives us options of more than one possible LLT for handling a report. Sometimes it may be that we understand terms differently, but overall we always code as reported, making the best approximation we can in our coding. We never make assumptions. And what we always have a picture like this in the sessions, the Let's Code sessions. So I could say to you, what do you see in this? Are you here for today for us to teach you, or are you here to learn? So, and it's a difference of perspective, isn't it? And it's the same sometimes with verbatim terms. I can see a term one way, and when I speak to Carol Ann, she may see it a completely different way. So it's having that discussion, having that multiple perspectives during this session, and that's what we're here for. Overall, coding is a balance between applying rules for consistency and using medical judgment so as to manage the risks to patients. It helps to use medical references, and you'll see that during the session today. And sometimes there isn't a suitable term in MedDRA at all, and you need to request that a new concept is added to the terminology. So with that, let's code together. And I'm going to switch my camera off at this stage because it can be distracting for you. So let's have our first example. The first example is mycosis plantaris, and we ask, first question we always ask ourselves, what's actually being reported here? Is it English? Is it another language? Or is it actually medical Latin? What part of the body is affected and what tissue? Can we find a suitable LLT? So if I look in a medical dictionary, Dorland's Medical Dictionary is our go-to resource. The first word I would look up is mycosis. Mycosis is any disease caused by a fungus. So it's some kind of fungal infection. And plantaris means plantar, the sole of the foot. So we know it relates to the foot. So it's a fungal infection of the foot. So now we'll go and browse MedDRA. See what we've got here. I can look for, firstly, I would always start with the words you've been given. Look up mycosis and maybe look up the plantaris as well. So there's the mycosis that goes to a fungal infection. That confirms what I knew already. But I want to see it really at a foot level. So let's see if I could put foot or feet or a plantar in this. Let's see. No, nothing comes up with foot. So let's try for fungal and foot. So we know it's the sole of the foot. Does that tell us any more? Should we be thinking foot? Should we be thinking skin, I wonder, for this one? Which we've got fungal skin infection is the PT there, fungal foot infection. Well, that's the PT for the fungal foot. Let's go to the browser and have a look. So that's what I was thinking was, let's go to that one, because it's multi-axial. And let's see down here what we've got. There it is. Fungal skin infection is the PT. And underneath it, we've got different synonyms for fungal infection, fungal dermatitis, and then fungus foot and is under there, fungus foot, fungal foot infection, fungal NOS, fungal foot infection. So that seems to be the closest. It captures the tissue type of skin at the PT level. That seems to be the closest. Let's see. Let's go back to our slides. So what would you choose? Would you choose the fungal foot? Would you choose fungal skin infection? Or would you just go for the more general term that I showed you in the beginning of mycosis, not because that captures the wording of the report? Or would you query for clarification? Yeah. It's going up, 23, 25. Yeah. I think that's everyone is going to vote. Fungal foot infection. Yep, that's a straightforward one to get us started. Well done, 89%. I agree with you. That's what we've got. Familiarize yourself with medical Latin because you'll see the same terms come up repeatedly. Maybe keep a little reference guide for yourself if it helps. Be clear of the anatomical site, here being the foot because it makes a difference. And then we know it's skin if it's foot. Look for the closest LLT to capture the site and the pathogen. And our final suggestion, as we all agree, is fungal foot infection. So now we have a similar term reported, mycosis at toenail. So what's the difference now? Does this one differ from foot or plantaris? Do we have a suitable LLT here? What would you code? This is a free text. You can tell us what you would select for this one. Fungal, and Carol Ann's going to put the verbatim term into the chat. So I know I whizzed past it quickly, but if it helps you, you can refer to it in the chat. Onychomycosis, onychomycosis. Onychomycosis, well, somebody knows their Latin, don't they? Fungal infection of nail. Fungal infection of nail. Well, we don't need, it seems like you're all on the case with this one. You're all exactly right. Fungal, so both of these link to the same PT. I can show you in the browser again. If I do what you do, let's put the word in you gave me in the interest of time. Onychomycosis. Do my search. There it is. It's an LLT and it is the PT as well. Go to the browser, right-hand click, and there it is. So under fungal, there we got all our fungal PTs. And there's onychomycosis in the middle. And we see that the two terms you gave us, fungal infection of nail, is an LLT under the PT of onychomycosis. So you could use either of those. Onychomycosis matches the wording because of the word mycosis. So here is a picture just to put you off your morning tea or wherever you are in the world, your breakfast. Onychomycosis from Dorland's. And here is our, what we would say, be clear of the site, find the closest matching LLT for the site and the pathogen, and use references, particularly if you're not familiar. And our final suggestion, I agree with all of you, onychomycosis. Thank you. Do we have any questions, Carol Ann, about either of those two? Let's have a look at the questions. Any questions on that? What about mycosis fungoides? That's a different one. Carol Ann's answered that one.
So thank you, Jane. We will now start with our main topic today, neurological disorders. And the first example is quite easygoing. Here, a loss of muscle power in the legs is reported for a patient. So please consider synonyms that could describe a loss of muscle power and make your proposals for LLT assignments. What would be your proposals here? Muscle weakness, lower limb, yeah. Muscle weakness, lower limb. Localized muscle weakness, lower extremities, weakness of. Yeah, you have replaced loss of muscle power with an appropriate synonym, that is muscle weakness. Muscle weakness, lower limb. Yes, this would capture the muscle weakness, but wouldn't capture the plurality. So lower extremities, weakness of would capture plurality here because both legs were affected. Thank you for joining. So perfect. Let me show you in the browser. Here we are. Session timed out. I have to log in again. Here I am. And here we are with the browser. And if I enter just weakness and search, you see that weakness is grouped under asthenia, under general disorders. So this is too vague. I would need to look for weakness in muscle using word stems in order to capture both muscular and muscle and search again. And then I find suitable terms. Here I have several hits, also muscle weakness. So let's do a right mouse click, go to browser and search in the browser and look for the LLTs underneath. So the PT is muscular weakness, and here we have all the PT, all the LLTs underneath. We have the weakness of upper extremities, the lower extremities weakness of. So this would really be a term that would capture the fact that both legs were affected, but it does not contain the information muscle, but it's grouped under muscular weakness. So in my view, this would be the best choice. It would be closest, not to the verbatim, but to the reported concept. Not to the verbatim because it doesn't contain the information muscle. Here we would need to choose muscle weakness, lower limb, but here we wouldn't capture the fact that both legs were affected. So let me switch back to my presentation now. And here just a reminder of what we just saw in the browser. So what could we learn from this exercise? Think about synonyms, medical terms, so what has been reported if you cannot find a suitable MEDRA term when using the original wording. So in this instance, replacing loss of muscle power with muscle weakness. Use word stems when searching in the browser so that your search is not too narrow. So using musk and not muscle in order to also capture muscular. And look for LLTs under the suitable PT that represents the medical concept to also cover the affected body site, capturing singular or plural if possible. You won't find plural and singular terms in all instances, but here we had a choice. Now, our final suggestion here is to select lower extremities weakness of under PT muscular weakness. Next example. This verbatim has a different wording, but also relates to both legs. Here it is reported that a patient fell backwards onto the bottom because the legs gave way. So what do you think? Is this clear enough to code? Do we know what is being reported? Is this just a fall, or is there a cause for the fall? And if there is a cause, can we capture it with MEDRA? How would you handle this event? Would you code it to just fall, to collapse of legs, to loss of control of legs, or would you split and code to fall and collapse of legs, or fall and loss of control of legs? Or would you seek further clarification and query? What would you do? Let's see. Oh, we have split of opinion here. Most of you vote for splitting into fall and collapse of legs, followed by fall and loss of control of legs. And others would seek for further clarification. So let me lock this poll. Here we are. So let me show you in the browser the option that we had. First of all, we have to capture the fall. And if we search for it, there's an exact and match in MEDRA fall, and it is grouped under injury poisoning and procedural complication, SOC. Now, how can we capture the reported legs gave way? Can this be considered a muscle weakness or just a weakness? Can this be considered movement disorder? Was this due to muscle fatigue after strenuous physical exercise, or due to a seizure or syncope? These would all be assumptions. The only thing that we know is that for any reason, the patient has lost control of legs. So let's check if we find something suitable. Lost control. Let us check whether we find something. And here we have some loss of control of legs. We have the loss of control of legs, and if I click on it, I see the term details. Here it's under general disorders, SOC. Let me check whether there are other. Go to the browser. Let me check whether there are other LLTs underneath. No, there aren't. Just one LLT identical to the PT. So this would be an appropriate term to capture this vague concept. Let me switch back. Here again, the difference. So the collapse of legs, we had this option as well. I didn't show it in the browser. The collapse of legs is a non-current term. You see it because it's in red lettering here in the browser and has a red square around it. Collapse of legs has a non-current status. So this is not to be used, this LLT is not to be used for ongoing coding. So the only option that we have here is the loss of control of legs. You may ask yourself why we have to capture the fall at all. Well, a fall may signal various medical disorders like dizziness, vertigo, syncope, balance disorders, gait disturbances, peripheral neuropathy, vision disorders, etc., etc. It should always be captured because it may have a relevant medical background. So in our example, it should be captured in addition to the cause because it may lead to subsequent injuries as well. The points to consider document contains a similar example where a fall was reported with subsequent fracture and asked for splitting as well. And here are our learning points again. If you get a report of a fall with additional information about its cause and subsequent events, capture everything that has been reported without making any assumptions. And if subsequent signs and symptoms are reported and clearly attributed to the fall, try to capture the post-traumatic nature of the reported event if a suitable MedDRA term is available. For example, if a fall is reported with a subsequent hematoma, split and code to fall and traumatic hematoma, not just to hematoma. And Jane will have a similar example later on. So in our instance, we don't have any information of subsequent injury due to the fall. So here we only have to code the loss of control of legs leading to the fall. In our next example, it is reported that the patient can hardly move his arm. So an unspecified restriction of arm movement. Is this clear enough to code? Is there a closely matching LLT, or are there any medical terms or synonyms that we could use instead? Which LLT would you select for this example here, for this verbatim? Paresis in arms, upper limb motor deficit, mobility decreased, arm paralysis, movement disorder, NOS, upper extremity dysfunction, or would you seek clarification and query? What would you do? Can hardly move his arm. Upper limb motor deficit, so lots of different opinions. Some of you think that this has a neurological etiology, but you know, it could be anything. It could be shoulder pain, so the really severe pain in the shoulder, so the patient cannot move the arm because of the shoulder pain. It could be a myopathy. It could, of course, has also a neurological etiology. It could be anything. It could be that the range of motion of the joint is reduced and limiting the movement of the arm. This could have very different. So most of you are still with the upper limb motor deficit. Let me lock this. Here we are. So most of you have voted for the upper limb motor deficit. So this is really, this would assume a neurological etiology, and this is not reported. So it would be an interpretation, it would be an assumption. Same holds true for paresis in arms and arm paralysis. And we would look, seek clarification by reporter would be an appropriate step at first, but often you don't have the opportunity in pharmacovigilance, for instance, to clarify the background of a reported event. Then you will have to find the best approximation to this verbatim. Now let me show you in the browser again. So what did we have? We had the movement disorder. Could this be because it could not move arm? Could this be an option? Right mouse click, go to browser. Here we are. So this is grouped under nervous system disorders. So it's obviously considered a nervous system disorder. It would assume a neurological etiology. And if you look at the hierarchy, this is always advisable to look into the hierarchy in order to see how this term is interpreted in MedDRA. You see that it's grouped under dyskinesias and movement disorders, together with other HLTs like choreiform movements, like dystonias, paralysis and paresis, Parkinson's disease, and tremor. So these are all neurological disorders. This would not fit this vague verbatim. Now let's look at the other options that we had, the more vague terms. Mobility decreased, for instance. Here it is, in search. Here we have our mobility decreased, and you see that it's grouped under primary SOC musculoskeletal, but it has secondary linkages to general disorders and nervous system disorders. So it would capture a potential neurological etiology. It also has a link to the general disorders that would really capture the vague concept, but also to musculoskeletal. So this would be quite appropriate for the verbatim that we have. But we also had the extremity dysfunction. Here we have it. And if I search for this one, here is the upper extremity dysfunction. Then we see that this one is grouped under PT musculoskeletal disorder. So a very vague term, really assuming a musculoskeletal etiology, not a neurological etiology. It's only linked to musculoskeletal. Now, what can we learn from that? Because the verbatim is very vague and may have a relevant medical background, we should query to get a clear understanding of the condition in question. But often, especially in pharmacovigilance, and this is something that you would rather see reported in pharmacovigilance, no further information can be obtained, and then one has to search for the best approximation, a more vague term that best represents the reported event and or the affected body site. So here, the final suggestions. We would definitely query or try to query, but if no clarification can be obtained, we have two coding approaches that are suitable. First approach would be the LLT and PT mobility decreased, not capturing the affected body site, the arm, but with linkages to SOC musculoskeletal and nervous system, thereby capturing potential relevant etiology of the condition. Or upper extremity dysfunction, capturing the affected body site, but with only one linkage to SOC musculoskeletal, so assuming a musculoskeletal etiology. We would miss the potential neurological etiology in this instance based on the MedDRA hierarchy. You can see that there is no ideal solution here, but whatever you decide to do, document your rules for coding such vaguely reporting move disorders, and make sure that these rules are applied consistently.
Yeah, that's interesting, Carol-Ann, isn't it? Because when we talk about this when we were practicing, I was adamant that I would code it to the upper extremity dysfunction based on the focus of the area. And you pointed out that looking at the secondary SOC, a link is useful for when you have your eye on analysis. Interesting. Yeah. It's interesting. Thank you.
So any questions,
No,
Jane?
we don't have any. The group's very quiet today, so feel free. I know quite a few of you. It's nice to see some of you back that we've had in previous sessions, so do join us and make your comments if you have thoughts. No, nothing there, Carol-Ann, so...
Okay, then I hand over to you again, Jane.
Back. Thank you very much. Thank you. So I'll For the next example. The next example follows on nicely from what Carol-Ann was, quite straightforward after Carol-Ann's guidance through the last one. Paresis of the left arm. Is there a closely matching LLT? Can we think of appropriate synonyms for this one if we need to, or can we find an LLT? So let's have a look. Well, looking again, we go to our references. Before I go to the browser, I always like to make sure I understand what the term reported means. Paresis, when we looked it up in Dorland's, means the slight or incomplete paralysis. And paralysis, in contrast, is loss or impairment of motor function in a part due to a lesion of the neural or muscular mechanism. So paralysis could be either from neural or muscular etiology. Or it could also impairment of sensory function is an option, which is known as sensory paralysis. So, and it refers us to hemiplegia, palsy, and paraplegia. So they're different versions, different types. Paralysis meaning plegia. We sometimes see that as the suffix. So paresis we have as a slight or incomplete paralysis. So what would you select here? Probably quite straightforward, this one. I should have said at the beginning that in this session this month, we chose the focus area of neurological, but a large number of the terms we're using today were suggested by our attendees at previous sessions. So please do, if you have thoughts, send us your suggestions for future. So I should have mentioned that at the beginning. So I see. I think everyone who's voting is voted. Not many of you, not as many of you voting as there are on the call, but yes, 89% of you said left arm paresis. So we see, let's just look down though what we have here. We have monoparesis, meaning one limb affected, monoplegia, one limb affected, but it's a paralysis plegia. And then we have muscle weakness upper limb, or we have upper limb paresis. Well, upper limb paresis isn't wrong, is it? Because an upper limb is an arm, but left arm is more specific. And we actually have the laterality there in the LLT. So this is what everyone says. And just as a guidance there, don't need to go to the browser on this, it's straightforward. But I just wanted to point out to you that paralysis and paresis, as we saw in Dorland's, they are related and they group together in the same HLT of paralysis and paresis. And if we look down, we can see we've got the plegia terms, meaning paralysis, and the paresis, meaning partial, incomplete paralysis. And here we have hemi. So this, I've opened the HLT to show you all these terms are under the HLT to distinguish between paresis and paralysis. We've got mono, meaning one limb. Then that's where we've got our left arm paresis. If we look towards the bottom there on the left, we've also got a hemi, if you knew that one side of the body was affected, and we've got a hemiparesis and a hemiplegia, and a monoparesis, monoplegia. And then as LLTs, sometimes we're able to capture the detail of left arm, leg, arm, etc. So there, again, get a clear understanding, look at the neighbours and search for the most specific LLT under the matching PT, the best PT. And there we would select left arm paresis or monoparesis, as you all agreed. Next one, another type of weakness here, left-sided weakness of arm and leg. Well, again, fits with what we've just seen. Is it clear enough? Can we find a suitable LLT or should we query? Well, what would you select for this one? I've shown you the possible terms there on that last slide. Left-sided weakness. We've got hemiparesis left, strength loss of, weakness of limbs, unilateral weakness of limbs, muscle weakness left-sided, see clarification. So it's not too late if you want to join us in the polling. The details are on the top there. You go to your browser and type in pollev.com. I see, because we're less than half of you are voting with us. Yeah, everyone's done. What would you select here? Unilateral weakness of limbs seems to be the most popular. Some of you are thinking about muscle weakness left-sided, and some of you are going for hemiparesis. Well, this is interesting because this is very similar to what Carol-Ann and the discussion we had. we were talking in preparation, we chose a term, then we changed our mind, we went for a different one. And it's interesting that the 3 terms you've chosen are all the ones that we were looking at when we were finalizing our slides of those 3 terms. Weakness of limbs is slightly less specific, and what happens there with the weakness of limbs is that you lose the laterality, you lose the fact it affects one side of the body. So this is what you've gone for as a final vote, locking the poll. You've gone for the unilateral weakness of limbs, or close second was muscle weakness left-sided. So we could browse. I'm not sure we actually need to browse at this stage. We can, because I showed you, didn't I, before? I think we'll move on in the interest of time on this one. Left-sided weakness of arm and leg. Again, get a clear understanding of the reported medical condition. Look at the neighbours of potential suitable PTs and look for the most specific LLT under the best matching PT. Well, you were all choosing these. So as I showed you on the previous slide, in the HLT for the paralysis and paresis terms, one of them there, the option is hemiparesis as a PT, and under that you see a number of different ways of expressing it. So hemiparesis meaning half the body, one side of the body is affected by an incomplete paralysis, and we've got the term there, unilateral weakness of limbs, which was your top choice, and then another one was the muscle weakness left-sided. The reason we chose as our final suggestion, if you like, is the unilateral weakness, is because it captures the fact it's half the body, and it doesn't add anything. We always say don't add anything when you code. So because it doesn't say muscle in the verbatim, we didn't choose the muscle weakness left-sided. But like I say, we had some quite consideration about this one. And I think a number of those terms under the PT of hemiparesis would be acceptable, but that's the one we think is the closest. Do we have any comments on that one, Caroline, or do you have anything you'd like to add?
No further comment. Just what you just said, that the muscle weakness left-sided would of course capture the laterality, whereas the unilateral weakness of limbs would not capture the laterality.
Know which side is affected. And with neurological conditions, it's sometimes good to know, isn't it? We don't always have left and right with our MEDRA terms. Sometimes it's because the terms are old and they've been in MEDRA a very long time. We tend not to add them unless it gives you more clinical information. And where the brain is affected or the nervous system, often you do see the left and right because it can be meaningful.
Yeah, exactly.
Information. So this next example then, brachial plexus paralysis. This is one that came in just, I don't know if it's last month or the month before. One of our attendees suggested, I know is one of the ones that was suggested. What is the affected anatomical site here? Is it clear? Is the event itself clear? Is there a closely matching LLT? Can we think of other medical terms or appropriate synonyms, or do we need to split? Now, this is a term, it almost looks like we want to know more. When I see this one, I want to know more about the case. I want to know more about the patient and what's happened to them for this to be reported. What is the brachial plexus? Well, here we see that it's a network of nerves. A plexus means network, coming from the spine of the cervical to the thoracic region, extending through and down. In brachial means that it affects the arm. So it extends down through the armpit. And we see there it ends with the 5 major nerve branches. And those are listed there down into the arm, the radial ulnar nerve, axillary nerve around the armpit, and the median nerve. So a diagram there at the bottom shows the network coming from the spinal column itself down and affecting in the arm and hand. So it's something that often you would have paralysis would be the result of, often it would be trauma, maybe some kind of accident. In an adult, it might be a car accident or a motorcycle accident, or in a baby, it's often due to paralysis of the brachial plexus is often due to birth trauma. It's where the neck is stretched away from the shoulder. So this is something that may have happened. We would like to know more, really, ideally, about what's happened to our patient in order to cause this paralysis. Again, we've got the definition there for paralysis, being a loss or impairment of motor function in a part of the body. Brachial plexus is paralysis of an upper limb, because as we just saw, it's the arm that's affected by those network of nerves. It could be a lesion of the brachial plexus, so it could be inflammation or tumor, or it could be some kind of injury. Because the brachial plexus, as we've just seen, involves 5 different nerves, you can subdivide it into upper brachial plexus paralysis and lower brachial plexus paralysis. And in particular, when it is due to birth trauma, when it's the upper part affected, that's called Erb's paralysis or Erb-Duchenne paralysis. And if it's the lower part affected, it's called Klumpke or Klumpke-Dejerine paralysis. So these are the two, this is our backgrounds that we've looked into, and the symptoms also can be affected, can be determined by where the damage has been done. So is it the upper or the lower part? And depending on which part of the plexus is affected, will influence the symptoms that you see. It could be whole arm paralysis, or it could be restricted to the shoulder, the arm, or even down lower to the wrist. So that's what we said about our background to the term. Anything to add there, Caroline, from a medical perspective? Anything extra you'd like to add there?
No, you covered it all, Jane.
So based on that then, what would you choose? What would our group choose? When we received it, I must confess, I thought this is a hard term for us to, I could understand why somebody suggested it. What do you think here? Yeah, not as many of you are voting this time. Shall I see? So brachial plexopathy. So plexopathy meaning a disorder with the plexus. Injury. Well, do we know there's been an injury? Injury due to birth trauma. As Caroline had told us before, when we were practicing for this, it often is due to birth trauma. Is it monoplegia? Well, it's paralysis, isn't it? It's a paralysis and it's the upper limb. Brachial plexus. Is it the arm paralysis, peripheral nerve palsy, or is it well, more of you voted now. Thank you for that. I've given you a bit longer maybe. So where are your votes going? Plexopathy, meaning disorder. Injury, which is, as we've seen, is often the common cause, not the only cause. Paralysis arm, well, that seems to be what's being reported. So let's lock the poll. Ooh. Injury to the brachial plexus seems to be the most common, most popular vote at the moment. Well, let's have a look in the browser. Let's have a look at what terms we have for brachial plexus. Let's clear my selection from where I was searching in the procedures before. Brachial plexus. I'll put plex because we know that there's a term called plexopathy. So let's have a look and see what brachial plexus terms we have. Hopefully you can see that's quite small with the web-based browser. We've got brachial plexitis, so inflammation of the brachial plexus, itis, brachial plexopathy, opathy meaning disorder, injury. We've got lesion. Or do we know there's a lesion? If lesion actually means anything. Neuritis, again, another inflammation. These I would think probably, do these go to the same or do these? Yes, these go to the same PT, both of them meaning inflammation. But that seems like it's got a very specific PT. Brachial plexus repair, injury to the brachial plexus or injury due to birth trauma. So, well, to be honest with you, I don't feel that any of those are ideal for what we've got. I'm not seeing a paralysis term there. Let's go to the browser and have a look. So maybe some of you would be right with your paralysis of the arm and not capturing the brachial plexus option. So the plexopathy is where the lesion term sits. Neuritis is the other one. So then there's the injury, which is, it's green because this is obviously I'm looking in the nervous system and it would be primary to injury to, but we don't know that. I'm really not comfortable with any of these that I'm seeing so far. So let's see. So based on what we've discussed, we would say Number one, get a clear understanding. We've said that, I think, in every single term today. Consider the age of the patient and the etiology of the injury. We really do need to know more information about this patient. Don't make any assumptions. Don't assume that it's inflammation. Don't assume maybe that there's a lesion, because we don't know, although lesion is a very non-specific term. And ideally, I would like to query and get more information. If it was a case reported through drug safety, you might have more information about the patient and details, or it's worth, if you're in clinical trials, it's worth finding out more from the investigator. Our final suggestion, based on all the considerations, is that ideally we would query if the paralysis is due to birth trauma, or find out the etiology. Is there a tumour? Is it due to inflammation, in which case you can code more specifically, or is it due to some kind of tumour causing compression, which can happen? The options, as we've seen, would be neuritis, brachial plexus neuritis, brachial plexus injury, or brachial plexus plexopathy, meaning a disorder. That's probably the closest we're going to get. Or you capture the paralysis itself, knowing it affects the arm, as some of you suggested with an arm paralysis, but we don't know what part of the arm could be affected. So that's where we would be going on that one. Do you have anything to add, Carol-Ann, on this one? I know you did a lot of research on it before.
No, other than what you have mentioned already, I do not have other suggestions. Other than birth trauma, of course.
Yes, birth trauma.
If you find out that it's a neonate, then a birth trauma would, of course, be the preferred option for coding.
Thank you. Do we have any comments from our group today on that one?
No questions at all. We have a silent audience today.
Yeah.
This should be interactive.
Yes, where's Magnus with us today? Magnus has usually got some comments, or some of our group that I was seeing, Martin, Barbara. It's good to see you joining us again. I'm looking down some of the names, so share your thoughts with us. Well, I'll hand back to you, Carol-Ann, for the next set. Oh, Magnus has sent us a comment. Oh, good. Let's have a look. Good. Oh, yes, I was presenting with that one. Oh, could we slow down a bit? Oh, I am sorry, Magnus. Yes, it's tricky that. Today, we're trying to fit a few more terms in, because we're getting comments, people saying, please try and put more terms into your session, particularly when we've aimed to do maybe 12 in a session. But thanks for that comment. That's useful. Magnus is saying we should slow down a bit. We're a bit too fast for people before making a decision. That's a fair point. I think I appreciate you letting us know. Good. I'll hand back to you, Carol-Ann.
Thank you, Jane. So here our next example, and I will try to slow it down again as well. But we were really told to really cover more examples per session, so that's why we try to speed up a little bit in our presentation. So next example. So here we are told that somebody was anxious and felt paralyzed. So there was a feeling of paralysis with fear when taking the piano exam. How would you handle this report now? Is it clear enough? Do we have to split? What are your suggestions here? Oops, sorry. Would you code this to anxiety, feeling anxious, anticipatory anxiety, situational anxiety, phobic anxiety, fear, performance fear, panic attack? So select all that apply. If you think this needs to be split, then select more than one term. So we have several different anxiety terms, fear terms, because both anxiety and fear were reported. I was anxious and felt paralyzed with fear when I said my piano exam was verbatim. Now let's see what your proposals are. Performance fear and situational anxiety are, most of you vote for this but others also for anxiety, feeling anxious, anticipatory anxiety, and just fear. So let me log this poll here. Oops, I think I've closed it. Let's look into the browser. And let me switch again, screens. So let's look for anxiety first. And I will do a top-down search here in psychiatric disorders. Here we have the HLGT anxiety disorders. And we are told anxiety is a symptom, so we are not told that this is an actual anxiety disorder, but it's an anxiety symptom because this person is feeling anxious. So here's our anxiety, PT anxiety. And you see that we have plenty of terms in there. Anticipatory anxiety is in there. We have the reaction anxiety, situational anxiety. So I think that situational anxiety would be the best match here because it's in the situation of the exam that the patient, this person is feeling anxious. Now, what about the fear? Fear is more than an anxiety. It's an unpleasant emotional state consisting of psychological and also psychophysiological responses to a real external threat or danger. So this is a real external threat for this person. It's exam situation. So I would quote this really separately from anxiety, from feeling anxious or from the situational anxiety. So let's check for the fear. And you see that fear symptoms and phobic disorders are grouped under a separate HLT in this SOC. And here, when looking for fear symptoms, we see a lot of fear terms, but nothing that would fit our situation here. But the performance fear, this is really a good term for the situational fear we have here, because performance fear is a fear in an individual or represents a fear in an individual by the requirement to perform in exam. You are in front of an audience and have to perform. So it's stage fright is another LLT underneath. Performance fear would be a good solution. Now, what about the reported feeling paralyzed? Do we have to capture this? The subject felt like being frozen, being paralyzed, but this has nothing to do with the diagnosis paralysis, so it has no medical background. The background here is really the anxiety, situational anxiety, and the performance fear. So in my view, the additional selection of an LLT under, for instance, PT feeling abnormal or suitable, some suitable LLTs underneath would not add relevant information. And therefore, this information, in my view, can be disregarded in this case. Now let me switch back.
We've got some comments, Carol-Ann, on this one.
Yep.
Yes, our audience are getting going. So we've got a few suggestions here. Now, firstly, wouldn't the LLT, situational anxiety, wouldn't that be making a diagnosis? Do you see situational anxiety as a diagnosis, or do you see it as a symptom put in context? How do you view that?
I think that's the symptom put in context, because we were told in the verbatim, I was anxious and felt paralyzed with fear when I sat my piano exam. So this whole situation is related to the piano exam, the anxiety and the feeling paralyzed and the fear. So these are the three conditions that the patient is reported in context of the piano exam. So I think this is not adding information, it's actually what has been reported in the verbatim.
So based on that, then, we've got other thoughts. Maria is saying, wouldn't you then code that to a panic attack?
No, panic attack is something different. Panic is really, it's even more than phobia. it's a really an irrational, it's an irrational fear. What we have, what we have here is a fear, a real fear, because there is a specific situation for this person, the situation to perform in front of an audience in the piano exam. So it's a real fear of performing. It's not a phobia, and it's not a panic attack.
So you say it's not a phobia. So other comments, Martin's saying that surely it's a phobia of exams. So what would be your classification then for when you would code a phobia of an exam? Because it's the exam that's the focus here, not the audience. So it's, why did you not choose phobia of exams, or why would you not choose that one?
Yeah, I would always make a clear differentiation between phobia and a fear. So a fear is a response to a real external threat or danger. And here we have a real situation, whereas a phobia is an irrational fear. So there is no real threat or danger. It's an abnormal fear, so to say. If you have a fear of an exam, this is more or less a normal reaction. It may be more pronounced in one person as compared to the other, but it's a fear, it's a real situation. Whereas phobia is something different. It may even lead to the fact that it really limits your daily life. So a phobia of exam may lead to the fact that you not dare to even take this examination, that you miss the examination because you are just incapable of taking exams.
So then I'll give you the last couple on this one, and then we'll move on in the interest of time, but it's good to have some comments. So then coming back on that one, Martin's saying, well, the response, the extent of the response is irrational. Well, is it irrational to be paralyzed by fear of an exam or a test?
I don't think so, you know.
Necessarily. I remember taking my driving test, and I literally couldn't move my leg at some point, but maybe that it was so scared. So paralyzed.
No, I think it's just a description of how somebody feels like paralyzed. You know, you have to perform and you have to act, and you have the feeling that, oh, am I able to do so? And you feel like paralyzed, but then you start.
And then the last one, Gabriel suggests, well, if anticipatory anxiety is where a person experiences increased levels of anxiety by thinking about an event or situation, and it seems to be related to an appropriate SOC, why would you not select this one, anticipatory anxiety? And that's one we looked at, isn't it, Caroline? That was one we looked
at as well. Yeah, we thought that based on the verbatim, you know, when it says I was anxious when I sat my piano exam. So it is really in the situation. It's not that the patient or the person was already, it's not a patient, it's a person, a person who was already anxious prior to this exam.
Yeah. Thinking about it
before, worrying about the exam and etc. etc. It's really the situation in the exam that is reported here.
That's the way we chose to go, but it's not far different. I can understand the rationale for choosing that one. I wouldn't say that one was strictly wrong as such. It's the different perspective on it. So,
I have to admit that many terms in the psychiatric SOC are sometimes really hard to differentiate, and you need a lot of medical knowledge also, and look for definitions of specific terms in order to clearly distinguish these concepts. And we have other examples later on.
Thank you all for your comments. We'll move on, Caroline, in that, so we can.
Okay, here again our two terms that we have looked at: the situational anxiety on the bottom here, and the performance fear. And the first takeaway from this is that we should always distinguish feelings, sensations from objective clinical findings, of course. So feeling paralyzed is not a paralysis. It's something completely different. look for the most suitable term to capture the concept always, and refer to medical textbooks if not fully sure about this, the concepts in the MEDRA terminology. And here, excuse me, and here the final suggestion: situational anxiety under PT anxiety and LLT performance fear, same PT. Next one. The next example is more complex. Here, an oncologist suspected a Horner's syndrome in a patient because she had noticed an eyelid droop after exercising and that only one half of her face was sweating. A CT scan then showed breast cancer metastases to lymph nodes in the neck, which were compressing the cervical sympathetic nerves. So when looking at this verbatim, first of all, you should be clear about what a Horner syndrome is. And you should be aware of the guidance in the PTC document for capturing confirmed or suspect diagnosis with related signs and symptoms. So what is a Horner syndrome? Here, the description from the online professional version of the MSD manual. And just to let you know that this is available in different languages, not only in English, but also in Spanish, Portuguese, French, Italian, German, Russian, and also Chinese. And you see the link here. So it's really a good source, internet source for medical information. We are told that this syndrome results from a disruption of the cervical sympathetic pathway and that it may occur centrally or peripherally. When peripherally, the interruption of the sympathetic fibers is located after these fibers' point of exit from the spinal cord. And related signs and symptoms are ptosis, miosis, so ptosis, a droop of the eyelid, miosis, anhydrosis, and hyperemia of the affected site. The image provides you with a typical clinical picture with the droopy upper eyelid and the miosis. Anhydrosis and hyperemia of the affected site are not really obvious on this photo. Now, how would you handle this report? Which LLTs would you select to capture the reported medical information? It's quite a lot of information that we get with this verbatim. Which LLTs would you select? Remember, Horner syndrome, droopy eyelid, only half of the face is sweating, breast cancer metastasis to cervical nodes, and compression of the sympathetic nerves. Yes, Horner syndrome, breast cancer metastatic, the suspect diagnosis and all symptoms, yes. Nerve compression, breast cancer metastatic, split between symptoms and diagnosis, yes. Droopy eyelid, breast cancer, anhydrosis. Yeah, let's check. Thank you for your suggestions here. First of all, you are all right. What we have here is a provisional diagnosis, a suspect diagnosis. And the points to consider document then provides us with a preferred option for handling such reports, meaning that we should code the diagnosis, the provisional diagnosis, and all signs and symptoms. So most of you have taken the right approach here. So we would have to code the Horner syndrome plus the droopy eyelid and the fact that only half of the face was sweating. That's first. And of course, then we would also need to code the results from the CT scan. Now let me again switch to the browser and show you. So Horner's syndrome, let me search. Here we have it, Horner syndrome. You see it is under nervous system disorders. but has secondary linkages to eye disorders and neoplasm. Some of attendees asked how to be able to see the hierarchy. So by clicking on this term, you can open the term details, and then you see the hierarchy. You can also do a right mouse click and say go to browser, and then you see the hierarchy here in this window that is opening. And when clicking on one of these terms in a SOC, like here in nervous systems, then the hierarchy will open up in the Explore window. So this is how you find the hierarchy. And so Horner syndrome.
Caroline, can you just also there, I forgot to mention before Geeta was asking, can you explain the difference between the red, the blue and the green while you're there?
Yes, the red and the blue and the green. You find it in the legends. Here they are. Really important to know be familiar with the legends. If you have a blue square around a PT, then it's a multi-axial term that you're looking at. It's in its primary SOC. If it has a green square around it, then it's a multi-axial term that you're looking at in its secondary SOC. And if it has a red square around it, then it's a uni-axial term. So then, of course, you only look at it in its primary SOC. So here you see I've chosen the nervous system disorder SOC, and you see some of the terms are uniaxial, so they have the red square. The blue ones are multi-axial, like Horner syndrome, you know that. But you are looking at this PT in its primary SOC. And some of them have green squares around it, like, for instance, here, diabetic gastroparesis. So, of course, this, if you click on it, again, you see in the term details window that gastrointestinal is the primary SOC here. That's why we are looking at it in its secondary SOC here. So this is how this works, the legends. Important to remember and to be familiar with. Now, let's continue with our example. Sweating decreased. Let's search for this term and then search in the hierarchy. Here we have a term. Let's go to browser and search for relevant terms under this respective HLT. So HLT, apocrine and acrine gland disorders. I don't know if I pronounced this correctly. I'm not a native speaker. So anhidrosis, that would be a good term to select, because we were told that the half of the face is not sweating at all. It's an anhidrosis. But we are told that it's half of the face. So let's check whether we even find a more specific term. And if you look into this whole grouping here, you will find hemifacial anhidrosis. So perfect term capturing our condition. It also groups hemiface sweating decreased. So hemiface sweating decreased is not grouped under hypohidrosis, because the fact that only half of the face is sweating is taking priority over the fact that it's only a sweating decreased and not a true anhidrosis. So hemifacial anhidrosis would be a perfect match here. Now, what about our droopy eyelid? If I enter droop and search, then I only find facial droop. Well, would this be sufficient? It's grouped under facial paralysis. So under nervous system disorders, it even doesn't have a link to eye disorders. So what I could do now is either think about a medical term that could cover the concept, like ptosis, for instance. But if I'm not, if I don't find or I'm not familiar with this medical term, I may also go to the eye disorders. Again, may take a top-down search and go for the ocular neuromuscular disorders, eyelid movement disorders, and here I will find my my term that is eyelid ptosis. Here it is, eyelid ptosis. So this would be our term to select. Of course, then we have the information that the patient has a breast cancer, and that breast cancer has metastasized, so it is a metastatic breast cancer. Here we have the term metastatic breast cancer. Then, of course, we know that there are new metastases to the lymph node. We would search for that one. Metastasis to lymph nodes, again, right-hand click, go to browser. Let's see whether we find some more specific terms even that would cover the fact that the cervical lymph nodes are affected. We find axillary, Virchow's node, no cervical lymph nodes. So metastasis to lymph nodes would be the correct answer here. And now the compression of the sympathetic nerves. If I enter sympathetic and search, I find quite a number of terms. Let's restrict it to nervous system to get less hits. So we have parasympathetic. No, these are all sympathetic nerve injury. Well, it's a compression. It's not an injury. Sympathetic posterior cervical syndrome. This is something more specific. So nothing that we could find here for sympathetic nerve compression. So then look for nerve compression and search, and here we are. We have the peripheral nerve compression, radial nerve compression, and the vague term nerve compression. So this is the only option that we have in this instance here. Now let me switch back to my presentation. Here again, the definition of drooping of the upper eyelid is a ptosis. This is the medical term. This could really be a severe condition, so needing a surgical intervention because the whole eyeball may be covered after all. And the Horner ptosis is somehow different because these are taken from the Dorlands. It's just a moderate ptosis that you see in the Horner ptosis. Again here, just to remind you that do not stop with the facial droop because you have found something with a droop, because it's only grouped under nervous system disorders. What we have here is a droop of the eyelid, and that's why you have to search for more specific terms, either top-down in eye disorders or by looking into medical textbooks in order to find the medical term for upper eyelid drooping, that is eyelid ptosis. Our learning points are to code all symptoms and the reported provisional diagnosis. When not finding a suitable term, use synonyms for the search, in this instance replacing upper eyelid drooping by ptosis. Also always look at the neighbors when finding a somehow suitable term in order to find an even more specific term, like in this instance, hemianhidrosis in our case, and capture all reported information based on the sequence of reported events. Here also the breast cancer leading to lymph node metastasis and compression of sympathetic fibers. And based on this, our final suggestion is to code to eyelid ptosis, hemifacial anhidrosis, Horner syndrome, breast cancer metastasis to lymph nodes, and nerve compression.
So we've got a couple of comments here, Caroline, around the diagnosis. Now, we talked about this, didn't we, when we discussed. Now, we've got a couple of suggestions around the diagnosis. Could the diagnosis be, or could we code metastasis to neck? Because that's the cause that's caused the rest as the symptoms. So could you code metastasis to neck, and then it's the metastases compressing the nerve and all the rest to see the symptoms? That's one comment. Another comment is the one that we talked about. When we've got a CT scan there that confirms the diagnosis, would we not then regard it as a confirmed diagnosis? And it was me, wasn't it, you, when we had the discussion. I was saying I am cautious about seeing a result and using that to confirm a diagnosis as a coder, because I don't feel that I have the medical background, and I prefer to code as reported. When it seems like it's provisional, I prefer to code it as provisional. So that was the comment that's come up there.
Yeah, metastasis to the neck could be other metastases, so other anatomical structures may be affected here. And what we have here is a metastasis to cervical nodes, to the lymph nodes, and we would always try to code as specific as possible. So it's a lymphadenopathy that we are talking about here. So I would not code this to metastasis to neck. With a confirmation of the diagnosis, yes, I agree with Jane. What it is it's a suspect diagnosis based on the verbatim, and you could of course argue that the CT scan then showed or somehow made the link between the syndrome, the Horner syndrome, and the nerve compression. So I would still have a conservative approach here and code all signs and symptoms. You may take this as a company diagnosis, and in pharmacovigilance, add this as company diagnosis in the respective field of the E2B report. But I would be conservative. Not if you open the store, allowing coders to make diagnosis, making diagnosis based on a verbatim like this one, this may cause troubles after all. So this is rather something that needs to be done on the medical assessment side.
Yes, I agree with that, Caroline. I think it's very dangerous to say when can we take it and when can we not. It's not our job as coders. So, that's good. Before you move on to that one, another question we've got relates back to the brachial nerve paralysis. If we knew that the brachial nerve paralysis, the brachial plexus paralysis, was a result of vaccination against COVID-19, would you then choose brachial plexus injury? Well, it is an injury, isn't it? Because of medication, like a medication error, complications, injection.
It's a complication of the vaccination. Yes, so it's a complication of the vaccination, and somehow it's an injury due to the vaccination. I think this would be an option.
Yeah, that sounds reasonable to me. Thank you, Caroline. Yeah. I'll let you get on. Well, I see time. We've got about 10 minutes left.
Yeah. So fatal stroke due to a large intercerebral bleed in a previous stroke patient taking a clinical trial drug to prevent further strokes. This is a verbatim that we received from a previous attendee. So it is a trial to prevent further strokes, and this patient suffered a stroke due to a large intercerebral bleed. So does it make a difference that the patient participated in a clinical trial to show the effectiveness of the study drug in secondary prevention of stroke in this instance? Would we code the cerebral vascular accident differently based on this information that we get here? And do we have to capture the fatal outcome? Please let me know your thoughts. What LLTs would you select here? Would you select stroke, recurrent stroke because the patient already had a stroke before, hemorrhagic stroke, hemorrhagic transformation stroke? Would you code pre-existing disease because the patient had already suffered a stroke before? Intracerebral bleed? Would you capture the fatal outcome by coding death in addition? Or would you assume lack of drug effect? Select all that apply. What would be your choice here? So we have several stroke terms we could choose from: pre-existing disease, intracerebral bleed, death, lack of drug effect. Now let's see what you have chosen. So hemorrhagic transformation stroke is something where you have an ischemic stroke first and then it transforms into a hemorrhagic stroke. This was not reported here. So we have a split of opinion here.
Oh, yes, a big split.
Let me lock this poll and continue with showing you in the browser here. So if we know that we have a stroke, and we know that this stroke occurred because of a bleeding. If I search, oh, I have to clear my selection first, otherwise I won't get any results. Let me search. So although I have entered bleed, the tool already provides me with hemorrhagic terms. This is due to the synonym list. This should always be activated. It replaces terms like bleed with hemorrhage or renal with kidney, etc., etc. So hemorrhagic stroke, this would be an option. We know that the stroke occurred due to an hemorrhage. If I go to the browser, you see that we have a lot of different terms under this HLT here. Here we have our hemorrhagic stroke, but under HLT, central nervous system hemorrhages and cerebrovascular accidents, you find a lot of terms. Thrombosis terms, embolism terms, ischemia terms, but what we have here is a hemorrhage. So hemorrhagic stroke would be one option for coding our reported event. So do we need to capture the intracerebral bleed in addition? Because a hemorrhagic stroke can be caused by an intracerebral bleed or by a subarachnoid bleed as well. So if this differentiation is relevant for the drug in question, then we may want to capture it. But on the other side, by doing so, we would duplicate the cerebrovascular accident. And this you may not want to, because it's really a serious event, and you would duplicate this event and make it 2 events in your database. And this is especially true for clinical study databases, which often do not allow to group signs and symptoms under one diagnosis. So the diagnosis would be hemorrhagic stroke, and the symptom or the sign would be the intracerebral bleed. So if you would like to avoid duplication of events in similar cases, you will need coding conventions with prioritization rules for coding strokes with different etiology and different intracranial localization in order to avoid this duplication of events. Let me switch back to my slide. Now, what about the fatal outcome of the stroke? Do we have to capture this by coding death separately? So the PTC document is very clear here and states that if a reason for death is reported, so a death with adverse reactions, adverse events, it is not necessary to capture death separately via coding. You all know that separate database fields exist to capture the fatal outcome, and these can be used to capture this information. What can we learn from this example? Because strokes are medically relevant events and quite frequently reported, make yourself familiar with the terms that are available for capturing the different types of cerebrovascular accidents. Capture the type of stroke as specifically as possible, potentially applying prioritization rules in your coding conventions, and to avoid duplication of events by splitting. Follow the PTC guidance on coding fatal outcomes and do not assume lack of effect. We don't know whether the effect of the drug was different because of drug or foot interaction in this clinical trial or due to patient non-compliance. So we cannot assume that this was really a lack of effect. There may be other reasons for it. The final suggestion would be to code to LLT hemorrhagic stroke and optionally also to LLT intracerebral bleed, depending on the requirements of the study, the structure of the database, and your coding conventions. And just one last word regarding this event, which occurred in a study investigating the efficacy of a drug in secondary prevention of stroke. In such a study, recurrence of stroke would be an efficacy endpoint. Usually, study endpoints are captured on separate CRF pages, not on the AE page, in order to capture more detailed information, like, for instance, the exact localization of the bleeding, related signs and symptoms, etc. So based on the study protocol, you may define that strokes must not be recorded as AEs in addition, because they are already recorded as a study endpoint. So this would also avoid additional data reconciliation of the entries to ensure that these double entries, either as study endpoint or as AE, are consistent. So this makes this scenario a bit different because it's a study case. Other questions? Jane?
Not on this one, Carol-Ann, no. The only question goes back to Katarzyna's question earlier about the vaccination site. And there was a comment there that the vaccination site, there's a better term. Martin's been in his browser for us. There's a better term of vaccination site nerve damage. What about that one?
Yeah, that would also be, that would be very specific.
So it's not in the injury SOC, it's in the general because it's a procedural complication. But thanks for that, Martin. That sounds like a better one, doesn't it? And then here we go. We've got a couple of questions coming in about the strokes. Apologies, I see we're on time, but please, if you can bear with us for a couple more minutes. Do the events reported on endpoint forms get coded? So your efficacy, they don't get coded then, do they, the events? And when you said it would be an endpoint, it wouldn't be coded as such.
They wouldn't get coded. They may be mapped to, sometimes you have like tick boxes, and they may be mapped afterwards to MedDRA terms, depending on the CRF design. You may have tick boxes with separate events or diagnosis, clinical signs and symptoms, and these tick boxes may relate to medical terms that represent MedDRA terms, so you can directly map those to MedDRA. But they would not be actually coded by operational coders.
And then a couple of questions, probably a bit big for the end, but one is, so we talk about clinical trial and pharmacovigilance coding. In clinical, you might do this or you might do that. And the question is around, do we have different coding conventions? It's not the coding conventions as such, is it, Carol? It's more the restrictions of the system. You're more restricted in clinical trials often. But so you have to code slightly differently. You can't always select two terms. Some companies are able to split, but not all. But would we have different coding conventions for PV versus the clinical trials?
No, I wouldn't have different. No, it would make life for coders very, very, very difficult. It would create inconsistencies. You may want to have a integrated safety database for certain products, and then you would like to have consistent coding approaches as well. So when we point at the fact that this is a study case or a pharmacovigilance case, this is mainly based on the fact that in pharmacovigilance you have a different database. So often you have the possibility to really group clinical signs and symptoms under a diagnosis and only consider the diagnosis for your searches or for subsequent analysis, and some of the clinical databases do not allow to do so. So their duplication of events may be an issue, not so much on the PV side. And also on the PV side, you often have these very vague terms that pose many more problems than really medical terms that are reported in clinical studies.
So, Geeta mentioned that earlier about the danger of double counting, which is very valid. You're right. I remember in one of the user groups live a few years ago, somebody suggested that the PTC document ought to have a version for clinical and a version for PV, and that just wouldn't work. We want to be consistent, but that is why the PTC document sometimes gives you options of handling, doesn't it, Carol? And the preferred approach is one way, but you can use another way, so long as you document it. So, and then the last comment, I'm not sure if we've really can do this one in the time, is about, can you mention what is hemorrhagic transformation of a stroke and when you would consider that? Because we had it as an option in our multiple choice and we discounted it.
Yeah, remember that we talked about the sequence of events. So hemorrhagic transformation stroke is a sequence. So first you have an ischemic stroke, and then as a complication of this ischemic stroke, you may have hemorrhages in this necrotic ischemic area. And this is then in hemorrhagic transformation stroke.
Thank you, Carol-Anne. So that's all the questions we've had today, and we are slightly over our time. Thank you all for your involvement, for your participation. It's great. I'm sorry we haven't got through all of our examples today. We will carry them forward, won't we, Carol-Anne? One of the comments that we've been given is that we should carry them forward. Are you going to do the last slides, Carol-Anne? That would be great. Yeah. Thank you, while you're presenting. So we are interested. Send us your suggestions. Based on feedback, we're going to try and have a focus area that we can communicate in advance. So if you've got ideas for focus areas, let us know. If you've got individual terms, send us those as well. You can contact us through the help desk, address it to one or other of us, and we'll pick it up. We can't do your coding for you, though. You have to code it yourself in the meantime, and we'll try to include it in a future session. And as you know, we do have different material every month, so please do come and join us again. It's lovely to see so many of you coming back month on month. I think that was everything. Anything else we need to say, Carol-Anne, for our group while we're here?
So just the links that we always offer to additional information, to tools that the MSSO is offering, also to the training schedule to find out what additional trainings are scheduled. So the next Let's Code Together sessions will be in May and in June. They are already posted on our website, and also the link to the support documentation. Here, how to contact the MSSO. This is a screenshot of the Medora website. If you click on contact here on the top, then you get the email address of the MSSO help desk. You can raise questions with. You can also follow us on social media. We have other social media channels, WhatsApp groups in English, Spanish, French, and Russian, and also a WeChat group in Chinese. We have a live chat function, and we also have an online contact form. So in the interest of time, in the YouTube channel on the website, if you click on it, you will be directly brought to our YouTube channel, where you find all webinars, all recorded webinars, also the Let's Code Together webinars. You know that we are offering different new verbatims with each session. Too much talking. Each session, so if you were not able to attend one of the sessions, then you can watch them on the YouTube channel, just to let you know.
And we've indexed them, haven't we, Carol-Anne? Since last month, we've indexed them so you can see back which verbatim terms are covered in which session. So we are taking your feedback on board as much as we possibly can.
Yeah, and here's our survey. So we always provide a survey at the end of our sessions, because your feedback is really very important for us. We adapt our presentations based on your feedback. We take your suggestions for verbatims. So please provide us with feedback in order to really meet your needs for training purposes. It will only take a few minutes of your time, so it's not really complex.
And we're getting some.
So if you have time now, please do so. Otherwise, you also get a email after the session with a confirmation of your attendance, and there you will also find a link to the survey.
Same survey, so you only need to do it once. Some lovely comments coming in, Carol-Anne. People saying they enjoy it. We'd love to see you back another month. It's great to see so many people. And Sophie as well, who I see is back with us this month, looking through the names. So it's good to see everybody coming back month on month. So Thank you, everyone, and hopefully see you next month. Thank you very much, Carol-Anne, for
goodbye, everybody.
Collaboration.
Goodbye for now. Stay safe and healthy.
Stay safe. Bye-bye.